Hello, my name is Olivia Richards. I am a third-year PhD student in the School of Information at the University of Michigan. And today I'd like to discuss my work with Adrian, Choi, and Gabriela Marcu in studying shared understanding in care coordination for children's behavioral health. I'd like to start by telling you about Catherine. She is a learning support teacher who provides supplemental behavioral support to children, such as Sam, who is autistic. She requests informational updates from Sam's teacher and parents to stay informed of his behaviors and progress. However, her biggest issue has been teacher follow-through, not just with Sam's teacher, but with other teachers amongst her caseload of 14 children. She said just getting in touch with them has been difficult, but then having them fill out a Google form or reach out to her about their behaviors is even more challenging. Some teachers don't even fill out the Google form. They don't have time, so they don't. Without being able to rely on documentation from other care team members, Catherine has had to observe Sam on her prep times and other kiddos as well. So to effectively support a child, Catherine has to make sure that she and the teacher and the family have a shared understanding of that child's needs, which requires coordinating with all of these individuals. Given the challenges that practitioners like Catherine experience with care coordination, we were interested in understanding how difficult it is to develop shared understanding on children's care teams. Shared understanding relies on information sharing amongst team members to construct and negotiate a shared mental model. In practice, though, achieving shared understanding is difficult amongst distributed teams because of differences amongst members and challenges with relying on technology-mediated communication. When information is not shared, practitioners such as Catherine have mismatches in information and a different mental model of Sam's needs than his teacher. We build on Starr and Geismer's work studying how boundary artifacts are used to share information and coordinate care across boundaries. However, Blar and colleagues showed how the use of technologies as boundary artifacts can at times disrupt the transfer of information, which would normally need to be disseminated in order to create a shared understanding. Our team's previous work describes significant breakdowns in the work of these types of care teams and their lack of shared understanding. Thus, we wanted to investigate shared understanding amongst distributed care teams to understand the barriers, practices, and the types of information that members of a child's care team need to develop shared understanding. Toward this goal, we conducted fieldwork across 3 different care contexts for children's behavioral health in the United States. First, a hospital-based pediatric feeding disorders program. Second, a social skills program in a private therapy clinic for autistic children. And third, an elementary school-based behavioral disorders program. This approach helped us understand how shared understanding is developed across the broader ecosystem of care rather than focusing on one specific organization. To this end, we conducted 51 hours of fieldwork and 20 semi-structured interviews with parents and the practitioners who staffed these programs. We asked them about their experiences coordinating care, how they interact with other members of a care team, and the information they would like to be exchanged amongst team members. We analyzed our observation notes and wrote memos and conducted thematic analysis. From our empirical work, we generated a conceptual framework of shared understanding and care coordination. We identified barriers here in the center of the framework that include differences in approaches and motivations, an inability to rely on documentation like Catherine, and information lost during transfer across the care team. I won't be able to dive into these barriers today, but I'd be happy to chat offline. Throughout the rest of the framework, we identify 2 key mechanisms that enabled care teams to overcome these barriers that I've mentioned. First, building relationships across boundaries, and second, sharing actionable information. We then identified 9 specific practices across these 2 mechanisms on the bottom of the framework that contribute to the development of shared understanding. On the left, building relationships across boundaries involved 3 different practices. One collaborative practice was engaging the whole person. Practitioners work tirelessly to understand and engage each child as a whole person rather than a set of deficits or needs. And play was an effective way to get to know a child. An informal conversation with a home caregiver helps learning about their home life. One therapist engaged children fully with a treasure chest to reward and motivate the children as they make achievements in the clinic. They often rig the game for the child's benefit. So if they know the child likes yoga, it might magically appear in the treasure chest as a reward. This helped to not only build rapport between the practitioner and the child, but also supported the effectiveness of treatment through the customization of rewards. Now here on the right side of the framework, the other key mechanism we identified was sharing actionable information, which we define as either prescriptive or descriptive. Prescriptive information helps teach or inform so that care team members consistently deliver care across settings. The prescriptive information sharing process involves more knowledgeable members of the care team training others to implement an intervention effectively, such as practitioners in the clinic training parents. One practice for sharing prescriptive information was experiential learning, which was used to prescribe information and teach practical hands-on skills. Following Kolb's model of experiential learning, parents learned behavioral interventions from practitioners in an iterative process of experiencing the skill through observation and then actively experimenting with real-time coaching. One feeding therapist described how when they train a parent, they'll say, "Did you see how the tongue was super flat? That's how you want it to look every time." They point out specific things to parents as they learn to be able to replicate that intervention at home. In contrast, though, on the right-hand side to prescriptive information, descriptive information is more contextual or holistic knowledge about a child in context. And this type of information sharing often requires a working relationship between care team members. One practice for sharing descriptive information was critical information sharing. In order to provide consistent care, practitioners need up-to-date information on a child's behavioral interventions and their behaviors to inform their work and perform it safely. One therapist in the social skills program shared the gravity of this need for critical information, saying, "If I don't know that every time you get close to this child, he's going to punch you in the face, that's going to be very unfortunate." And unfortunately, this happened to her several times. Overall, these 9 practices shed light on the opportunities and limitations of technology for supporting the delivery of distributed behavioral care. On the left-hand side, the practices for building relationships across boundaries would be difficult to replicate or enhance using technologies. So this is not where our design recommendations lie. However, we think designers should keep these in mind to make sure that technology does not interfere with these important interactions. These 6 collaborative practices for sharing information could be incorporated into the design of technology to more effectively engage distributed care team members and deflect the impact of the barriers to support care coordination through both prescriptive and descriptive information sharing. Our work has a few key limitations. First, this study was based in the United States and may not adequately reflect non-Western cultures. Second, our results represent the caregiver perspective, yet there are questions that can only be addressed from the perspectives of children. Accordingly, our design recommendations reflect caregiver interests and don't thoroughly account for the interests and capability of other team members or the care recipient themselves. We are so thankful for our participants and various colleagues for their time and support with this work. Please reach out if you have any questions or want to discuss this work further. Thank you so much.